You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Celine Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best, no matter what your hormones are doing. This show is a production of Live Feisty Media. Hello, strong, feisty women. I hope you all are well. So last year, around this time, I had a conversation with Dr. Stephanie Faubion, the medical director of the North American Menopause Society, to talk about the current state of menopausal care. Well, Dr. Faubion is back, and she is still the medical director, but now it's of the Menopause Society, which, for those who don't know, is the new name of the North American Menopause Society. They rebranded back in July with a new name and a new logo, a much better logo, if I must say, and a broad mission to lead the conversation about improving women's health and healthcare experiences. And she has a new book. It's called The New Rules of Menopause, a Mayo Clinic guide to perimenopause and beyond. So I thought it was a good time to bring her back in and talk about where we are now and what those new rules are, and all about the current state of menopausal therapies, because even though it was only a year ago, the conversation around hormone therapy specifically has been moving at the speed of light these days. And I want to make a note that about midway through this conversation, we get into a discussion on hormone testing, specifically testing hormone levels as part of prescribing menopause care. And I'm going to be honest with you, this is one area that I have been really trying to wrap my mind around, because I see women arguing in our social media groups and in the Facebook group all the time. And some, and maybe you're one, insist that testing is the only way to get hormones right. And others saying hormone testing isn't necessary, or worse, it's a scam. And I have dug into this an awful lot over the past almost 3 years now that we've been doing the show. The Menopause Society guidelines specifically say, and specifically, I'm going to read it here, that the use of serum, salivary, or urine hormone testing to guide hormone therapy dosing is considered unreliable because of differences in hormone pharmacokinetics and absorption, diurnal variation, and individual and intra-individual variability. A new report out in the British Menopause Journal says about the same thing. Tracking serum estradiol, estrone, or SHBG is not recommended, as it has not been shown to correlate with symptoms. Pretty much every guest I've had on the show, including double board certified reproductive endocrinologist and OBGYN, Dr. Carla DiGirolamo, and the co-founder of the Menopause Center, Dr. Claire Spencer, have said the same thing. Testing is not necessary. During our conversation here, Dr. Faubion also says the same thing, and she says it in her book as well, that hormone levels from labs don't necessarily reflect what is in your tissues, and that there are no predetermined levels, hormone levels, that all peri or postmenopausal should be aiming for. Treatment is based on symptoms. Yet, obviously, many women still want their levels tested, and many practitioners still test. And here is where I'm going to give you a little peek behind the curtain and a teaser for the upcoming show. Right after I got off the call with Dr. Faubion, I thought, I'm going to be interviewing Dr. Heather Hirsch next week, so I should dig into her book and see what she says on the topic. And wouldn't you know it, she does talk about hormone levels and testing hormone levels. So I took that opportunity to ask her what's behind that, what is her philosophy on all this. And I don't want to go into it all here, but suffice to say, she had a good answer that basically says you don't really need them, but they're a piece of data that can be nice to have. And, we have a much deeper and more nuanced conversation than that, and you'll hear that in a couple of weeks. But I wanted to give you a heads up that that conversation is coming your way, and that I'm not just dismissing this idea of testing hormones, even though all of these societies say all of these things about it. It's a nuanced conversation, and I really appreciated Dr. Hirsch being open to just having that discussion and to those questions. Okay, before we get to it, As always, check us out on Instagram and Facebook at Feisty Menopause. Sign up for my free weekly menopause blog at feistymenopause.com. You can learn all about our Level Up membership there as well, where we bring in guests 3 or 4 times a month and have pretty much intimate conversations about all of these topics. And again, thanks so much for your continued great reviews and 5-star ratings. They are helping me continue to grow this show going into our oh, it will be the 4th year pretty soon, which is really exciting. And finally, very quick thanks to AminoCo for their continued support. Women need amino acids, essential amino acids, and they have got them for performance and healing and more. We love their products and appreciate their support. Thanks, AminoCo. You can check out the show notes for their special listener deals. All right, enough of me. Let's have a few words about those awesome sponsors and get on with the show.
Hi there.
Good morning. How are you?
I'm great. How are you doing?
I am well. It's nice to have you back, and I'm sure you have
Yeah,
a
thank
very
you.
full day of
It's
people
a bit,
asking you questions
it
today.
is a bit full. Looking at it, it's slightly intimidating.
I am sure. I was like, I think I'm going to get her first. I think when they offered, I was like, I think I'm going to try to get that first one.
That was a good move.
Yeah. So, I want to respect your time, and I know you do have a lot going on. So, unless you have any questions for me, I will go right
No,
into.
I think we can do it. Thank you.
Okay. Well, it is great to have you back on the show, and congrats on an incredibly thorough book. I have written a few books myself, and I know what an undertaking that is. What inspired you to write The New Rules of Menopause?
Well, our last book was in 2016 and it was out of date. And looking at what's out there now, there's so much misinformation about menopause. And really, I think women just need a reputable resource. And so we dug in and got it done. And I'm really excited. I think it's a great product overall. And I think women will enjoy it and get a lot out of it, hopefully.
Yeah, I agree, and I'm curious a little bit about the name because I know that's a really big decision when you write a book. It's like, what are we going to call it? What inspired the New Rules of Menopause?
I was thinking about that when you were asking the question, and actually, I think this came from something that I tell women because they always come in my office complaining that their bodies have changed and they don't understand what happened. And what I end up telling them is the rules of your body have changed and someone forgot to tell you.
Ah,
Because everything that had been working for them before isn't working now, right? So it's like, what the heck happened? And it's the rules changed.
oh, I like
Um,
that.
so that's where that came from. And of course, there were many, many people who were involved in picking that name as
Oh, I
well.
know. I know how those conversations go. I like
Yeah,
that.
yeah, yeah. So I'm happy with it.
So let's dig into a few specifics. As you talked about, like it feels like 10 years have gone by. I mean, I started the show in 2020 and the conversation on hormone therapy has changed so dramatically, even over that period. And I feel like women that I see in my orbit are very interested in hormone therapy. What surprises me is how many are still met with resistance or this antiquated messaging, even from their primary care provider or the OBGYN. They're being told you're too young for that or hormone therapy is dangerous. Two related questions, like, is your impression the same? Like, is interest really going up in hormone therapy among, the US population specifically, I guess? And do you see that increasingly women are seeking it out?
That's a great question. And I don't really think we have good data to say that women are using hormone therapy more now than they were before. I do have more women asking questions about it, but you have to remember that I'm probably seeing the 1%, right, who have taken the time and the trouble to seek out an expert. And most women don't have that. Most women are seeing their primary care providers. So while more women may be asking those questions, I'm not sure more women are actually getting a prescription.
That's a good answer. And I remind myself too that I'm also seeing a biased circle of people, right? Who are like very actively engaged in trying to solve this puzzle, if you will, in their life. So
Exactly. But I think the recent media attention has been super helpful. And I think
New York
now women
Times.
are going, oh, wait a minute, maybe I should be asking some questions here. So I think that's been nothing but good.
Yeah, yeah, very good point. And then the second piece of that is how do we bridge that knowledge gap, Dr. Faubion? Like you know, it- we have the statements coming out, on hormone therapy from the Menopause Society, books like yours. How do we get that information into the hands of the providers who are caring for these women who are asking these questions?
Boy, that is a key question. I don't know the full answer, but I think it's going to be a multi-pronged approach. So I think it's getting at some of the educational training programs that physicians are in. That includes OBGYN, it includes family medicine, it includes internal medicine. And I'm an internist. I'm not an OBGYN, and I really think it's the internists and the family medicine doctors of this world that are going to have to own this. And in the past, they really haven't thought of, hormone therapy as being in their realm. They have thought of it as being in the realm of a gynecologist. But, let's face it, there are not enough gynecologists on the planet to take care of all the women who may need hormone therapy. So we have to make this easier for physicians to understand. And, that's educating them with CME programs. But I also think it's, can we even get this into the electronic medical record to where we can identify women who, may be having trouble, maybe having symptoms, and we can ping them in the record and say, hey, your patient has a complaint of hot flashes. She's X number of years old. We think she may be a candidate based on her past medical history. She doesn't have a history of a heart attack or a stroke or breast cancer, et cetera. So I think we could almost build this in algorithmically to some medical records too. So I think there are a lot of options.
Yeah, I agree with that. And that made me think that a friend of mine actually sent me an email that she got from our medical system here that when she hit, I can't remember what the age was, but they're like, hey, we have this menopause education program if you're interested, which is amazing. I was like, that is
Fantastic.
right.
I
I was like,
love that.
whoa, like that's amazing. That's great.
Yeah, that's wonderful. I think we as you just pointed out, women need the education too. It's not
Yeah,
just providers, because I have women in my office all the time complaining of various symptoms that might not seem like they would be related to menopause, but can be. Like some of the mood symptoms or
anxiety.
joint aches, for example. There's a bunch of stuff that you wouldn't naturally tie to the menopause transition. So I think women actually need that education as well.
No, you are 100% right on that. And what do you think, before we leave that on, there's an upsurge of online, you've got the Gen Evs and you've got Electros, you've got all these online providers. What is your thoughts on the rise of telehealth in that realm?
Well, I think telehealth is here to stay. We're all using that. Patients want it. It's good. I think the question is, what is the quality of the telehealth? And that, from what I've seen, is highly variable out there. And so, if women can be connected to a certified menopause practitioner, um, who knows what they're doing and who's offering evidence-based care and is making sure that they are taking into account that woman's risk factors for heart disease, for breast cancer, et cetera, and then can assure some sort of follow-up, um, and making sure she's had her screening mammogram and her pap smear and all that stuff. So that's a lot of stuff to make sure happens, and I don't think that's happening in all of these telehealth visits for menopause.
Yeah. Yeah, that's an excellent point. I'd like to dig in a little specifically on hormone therapy because it is such a big topic right now. And, going through your book, when you read the health considerations regarding menopausal hormone therapy between like oral and transdermal, every time I read these things, I think transdermal seems to have so many more advantages when we're talking about the potential health risks. And I wonder why we just don't all go that way. Like why is that? Why don't we just all move to a transdermal route?
Well, I think for the most part, that's what we do prescribe as first line therapy now. And, that would be the preferred choice for women with any kind of cardiovascular disease risk factor like hypertension or obesity or diabetes. And let's face it, probably the majority of the U.S. population. But, still, the oral estrogen is the cheapest thing out there, oral
Okay.
estradiol. And so there's a cost consideration. And, for some women who are young and healthy and, their insurance doesn't cover the patches well, which is another issue,
Yeah.
that might be a viable option.
Excellent point that I had not considered. Because I have not taken those routes. We need Dr. Faubion to talk about bioidenticals, of course. And it's interesting, you say in your book, like, even though the FDA has quote unquote bioidentical products approved, they don't use that term. I'm wondering, do we know why? Like, is there something wrong with that term? Because it seems I answer this question like 12,000 times a day. And I think that if it said bioidentical, it would really help.
Well, bioidentical, that term was made up as a
I know.
marketing tool by pharmaceutical companies. And so I think what we need to be clear about is that this term just means that it's chemically, structurally the same as what your body used to make. And that's what women need to understand. There's nothing magical about that word. We just need to all level set and be on the same page about what we're talking about, I think. So, unfortunately, it's called a few different things. I've heard it called body identical, bioidentical. Some people call it natural, but there's nothing natural about any of these things. They're all synthesized in a lab,
Yeah.
So when you talk about synthetic, well, theoretically, they're all synthetic, right? They're all kind
Yeah.
of made. It's not like you're smearing wild yam on your skin, I mean, it's all coming from something.
Yeah, yeah. And and along those lines, looking at where the research is going, I'm wondering, well, it seems logical. Like, if I'm sitting here and I think logically, what would I gravitate to for a hormone therapy? It does seem logical that I would want something that is as close, to what my body makes as possible. And correct me if I'm wrong, but aren't we seeing that those are seemingly in research coming up with better safety profiles? I'm thinking progesterone specifically.
Progesterone specifically, but when you go to estrogen, I'm not as sure.
Mhm.
Because you take conjugated equine estrogens, which has shown even the potential for decreased breast cancer risk
Right.
when used without a synthetic progestin. Um, then you get to that compound of estrogens may have some um, anti-estrogens in it, if you will, which act on the breast in a different way. And so some of these may be beneficial for some indications, and we just don't know enough about the differences between estradiol and some of these other products. So I think we'll learn more going forward. But again, I say, this is my mantra, we need to stop referring to all hormone therapy as just one lump term, because these compounds are very different. They're heterogeneous and they affect the body in different ways. And so a hormone is not a hormone, right?
Yeah, yeah. And then in the realm of progesterone, I mean, is micronized progesterone seemingly the way that the industry is going to be going?
Well, I think that's most of what is prescribed.
Yep,
Unfortunately, we still run into some insurance coverage issues on that, where they favor some of the older synthetic progestins over micronized progesterone, which
gotcha.
doesn't make a lot of sense. But fortunately, it is available as a generic now, so cost is
Oh, good.
becoming less of an issue.
Yeah, no, that's great. That's great. Thank you for that clarification. We can't speak about this without going into the compounded, without going into compounded products. And, in your book, and this was just a clarification, you note that one sampling of bioidentical custom compounded products conducted by the FDA found the ingredients varied significantly with what was stated on the label. Was that hormonal product specifically that you were referring to in the book?
Yeah, yeah,
Whoa.
and I can't remember if that was an FDA study, but I remember the More Magazine study, which I don't often quote More Magazine when I'm talking about scientific stuff, but this was, I believe, back in 2012, and they did a study of it was 10 um, compounding pharmacies that were online and a couple of brick and mortar ones, I believe. And what they found, they analyzed what was on the label. They looked at what was on the label and then analyzed what was in the bottle, and it was completely different. So the estrogen component was 260% of what was on the label. And the progesterone component was about 60 to 80% of what was on the label. So women by and large were getting overdosed on estrogen and underdosed on progesterone, which meant that they were at risk for the uterine lining building up and even endometrial cancer. And so another problem is that there's not good record keeping in terms of the adverse effects of
Mhm.
this of compounded hormone therapy. So we don't actually know how many women out there may have gotten uterine cancer because of it, because there's not good recording.
Yeah, that's many layers of problems there. And I also must note because I don't know what to think of this, if I'm honest, Dr. Fabian, is that I hear about hormone testing. It's everywhere. Like, I'm gonna get my hormones tested. I'm gonna get my hormones tested. I'm gonna get like my we have a complimentary, it's got 25,000 women in this group, and I hear so much of it. And I see in your book that you do not recommend hormone testing anywhere in this pretty, I don't know how many pages it is, 388-page book. Um, because hormones vary so much day to day, hour to hour, that it doesn't tell you what's in your tissues. There's no I'd like you to say that for me. There's no definitive predetermined hormone levels to aim for. What is happening? Like, I get what please talk to me about this. Like, why is this such a thing, and what should women really know about it?
Well, here's the thing, just because you can doesn't mean you should, right? So in some ways, maybe we have the ability to check hormone levels now in a way that's better than in the past. However, I would caution people because hormones are tricky to measure, and we really rely on very precise ways of measuring them. So what you're getting out there with either a finger stick or a saliva test or a urine test is probably inaccurate to begin with. So let's just state that. But what you mentioned about hormone levels not being useful is also the case, especially in perimenopause when you're still menstruating periodically, you haven't gone through a year without your periods. Those hormones are up, down, and sideways. So measuring on any particular day doesn't give you useful information. And then for postmenopausal women, I have women coming in all the time with hormone levels. Well, I don't have any estrogen. Well, yeah, you're in menopause. You're not supposed to have any estrogen. So it doesn't mean that we have to fix that, right? So it's not about the level. It's really about what symptoms are we trying to address for you. And here's the other thing. If you come in saying, I'm having a lot of hot flashes, what should my level be? Hmm, There's another one. We don't know at what blood level of estrogen any one woman will stop having hot flashes. So we are not aiming for a particular level. We want to know how you feel. So we start, your estrogen dose and we bring you back and we say, did we fix the problem? And that's how we know that you're at the right level for you.
So let me jump off of that and say that the messaging that women are hearing is that it's because you don't have estrogen that your brain, your heart, all your health is at risk, and you're just, you're deteriorating. These words, it's almost being treated like a disease state. And I, like, full disclosure, I am not on hormone therapy. Everything seems great, but I get really paranoid now that maybe I'm not doing the right thing. But like, where are we with that? I mean, what, because I understand women saying, "Oh my God, look, I don't have any estrogen. I am doomed." But that not it doesn't necessarily mean that you're doomed. I don't feel doomed.
No, of course not. And that goes back to the assumption that losing estrogen at menopause is somehow a disease state, like you stated, and that replacing it would then be an anti-aging technique or the fountain of youth in some way. And we just don't have any evidence for that, unfortunately. We do know that estrogen protects against bone loss and reduces
Mm.
fracture risk. We know that it's at least not harmful for the heart in the 50s and may actually be somewhat helpful, although it's not indicated for that in the absence of menopause symptoms. And we have no evidence that using estrogen in your 50s is going to reduce your risk of Alzheimer's disease. It appears to be neutral for dementia risk for women in their 50s. So when you step back and look at it, It's not the fountain of youth. It's not an anti-aging serum. We shouldn't be using it for that. It's mainly for symptom management and for some women for reduction of fracture risk. It's
Mhm.
also useful.
Where does testosterone fit into this picture?
Yeah, great question. So we don't fall off a cliff with testosterone at menopause, like the other ovarian hormones. So instead, we lose testosterone slowly with age, such that at the age of 40, our levels are about half what they were at 20. Same for men. Do we need to replace testosterone in women? No, we don't need to replace testosterone in women. And in fact, some very well done studies have shown us that the only real indication for the use of testosterone in a postmenopausal woman would be hypoactive sexual desire disorder. And that's a fancy word for low sexual desire that's not related to anything else. So that's really it. It's not FDA approved. We don't have long-term safety data in terms of the heart or the breast or the brain with testosterone in women. The safety data only goes out a couple of years. And with that data, it looks pretty safe when used to get that level just within the normal premenopausal range. So we're not aiming for getting anybody in the male range. So the majority of women do not need testosterone therapy. I'll just end with that.
A lot of them are getting pellets.
Yeah, and that's even scarier because the pellets are often very poorly made and they often disintegrate. And I've seen women with testosterone levels that are well beyond the male range. And the problem is you can't do anything about it. You just have to wait for it to wear off. So it's strongly advised against pellet use for women.
Yeah, we've said that a lot, but people, the message is not. We're talking about those information bridges. That's on my end and our end, and we're working on it. But there's a lot of information to get bridged out into the.
Well, thank you for that. Keep trying.
I'm trying very hard. I have a kind of a nuanced question for you. I was listening. I'm sure you know who Dr. Peter Attia is, like, because he's all over everything. He had a show with Dr. Joanne Manson on, about the Women's Health Initiative, and they had quite a long conversation at it. And at one point, he's quite pro hormone therapy, and I think pro hormone therapy. And I'm kind of putting words into him, but maybe not, almost as like, I think kind of everybody should go this way because it makes sense. But he also said that he questioned if we can use any of the studies from the WHI era in our meta-analyses because hormone therapy itself has changed so much over that 20-year span. And I'm wondering if you have thoughts there.
Well, I get what he's saying because he's saying it's a different type of hormone therapy
Yeah.
than what we use now. But here's the kicker. That's pretty much all the data that we have that's randomized controlled trial data. There's very little data out there, and that by far is the biggest study that we have. So it's the biggest and the best study that we have. To say that it shouldn't be used for analyses is rough because then we really don't have much at all.
Yeah.
And the issue is that nobody is going to spend $1 billion on a trial again because in the NIH's mind, I think if they've answered that question, which, there's still a lot more questions out there, but a trial of that magnitude
Yeah.
probably will never be done again, unfortunately. But so therefore, we have to work off the data that we have, and that does include the WHI data, and I don't think we should just throw it out.
Yeah. Yeah. I would agree with that. Because there are many ways that you can parse that data. And I think people have been kind of intelligently at this
And,
point.
and we just have to say, like I said before, not all hormone therapy is the same.
Yeah.
We have to recognize that trial was done with conjugated equine estrogens and medroxyprogesterone acetate, and that's what the results pertain to. They don't
Yeah.
pertain to micronized progesterone. They don't pertain to transdermal estradiol. So these are very different, but we can take it for what it was, right?
Yep. 100%. And just go forward. I 100% agree. Speaking of speaking of all of this, I think in this era of new rules of menopause and where we are now, it is really important to speak about that symptoms, that your hot flashes are not just something that, is like you need a fan and are annoying. the one of the most interesting things that I've seen coming out, going to the Menopause Society meetings and following this literature is that connection between the severity and the frequency of your symptoms and maybe serious health implications, whether it's might matter hyperintensities in your brain or heart disease. Can you speak a little bit about the connection between the symptomology that can happen with menopause and those chronic diseases? And then do we know if taking care of it then mitigates that risk?
Yeah, great question. So we have a lot of preliminary data, and most of it is from SWAN, so the study of
Okay.
women's health across the nation, that shows that hot flashes may not be benign, and the women who have more hot flashes, more severe, more prolonged hot flashes, tend to have more markers of heart disease, and even in some recent studies, more adverse outcomes later on in terms of heart disease and stroke. Um, there's those studies do need to be repeated in other populations to really confirm that. And also, as you mentioned, there are some brain changes that are associated with hot flashes too. And it's chicken egg. Did the
Mhm.
hot flashes cause that? Is it a common mechanism that caused both? So there's a lot we
Right.
still haven't really tied together. And your question at the end was great. Do we know that mitigating the hot flashes or treating the hot flashes would then change your disease outcome later on? No, we have no idea that that's the case. So yes, while hot flashes may not be benign, and I think that's a great point to make, I think we can also say they're not benign in terms of their effect on quality of life.
Yeah.
So women are suffering, they're not sleeping, they're getting to work, they're not functioning well at work. And the study we just published a couple of months ago says they're actually missing days of work
Right.
because of their menopause symptoms. So I think it's fair to say that menopause symptoms that are untreated are not benign, for any of
Yeah.
us, and not for the US economy.
Yeah. No, that's an excellent point. And it's good enough as a means to an end just to have a better quality of life, right? No matter what.
Right.
Yeah, that makes 100% sense. The final question for you, and then I will let you go because I know you have a very long day ahead. As I appreciated that you included a section on embracing your third act. Because I personally think that this is a super powerful, exciting time of life, and um, it can get painted as this terrible disease negative brush, and I fight that with everything I have. Um, and you also talk about taking care of some of maybe the body image issues and the things that will keep you from embracing this time of life. With all of this, I would love you to leave us with some ways that you recommend women protect themselves who want to embrace this time of life from the predatory marketing that is descending on us, that really hones in on those body image self-conscious aspects of this. And if I see one more thing like about the menopause or about all these things, it's just like it's terrible. It really bothers me.
Well, and it makes us think that aging is somehow, something to be embarrassed about.
Yeah. Yes.
And
And
and it's
ashamed
very
of.
interesting that we don't have the same type of marketing campaigns for aging men. And when I have women coming in, pointing to this body part or that body part, and I asked them about their partners, and their partners may have a belly as well, but they don't seem to be bothered by that. And I'm like, there's a double standard here for women, and it doesn't seem like we really ought to be obsessing over every little thing on our bodies. And you know what? You might have been a size 2 when you graduated from high school, but is it reasonable to expect that you're going to be a size 2 at the age of 60? Probably not. But you know what? You can be perfectly healthy a couple of
Yep.
sizes larger than that. And I think we need to start thinking about health and health span rather than the physical stuff. I mean, my body measurements, or the way my clothes fit, or my wrinkly skin or my thinning hair, or whatever it is. The goal is to be healthy, and to have that health span that we can really take advantage of these years after menopause. And let's face it, we're now living 1/3 to 1/2 of our lifespan after we have our last menstrual period. That's never happened before. That's never happened before for humans, for human females anyway. So this is brand new territory, and I think we need to figure out how to maximize, our quality of life and our ability to continue to do what we want to do. It's not just how many years that we live, it's how many healthy years we live, right?
Oh yeah. And we're all about, if you do, and I personally believe this, if you feel strong and vital and you're living this healthy life, the rest of that kind of takes care of itself a little bit better because you feel
It does.
better.
It
Yeah.
does. And if there is a fountain of youth out there, it's probably not hormones, but if there is a fountain of youth out there, it is a healthy lifestyle.
Yeah.
Are you doing all the things that you can be doing to maximize that? And everything that's good for your heart that you hear about, meaning get enough exercise, get enough sleep, stay on a regular schedule, maintain a healthy weight. The quality of your diet is important. All of those things are going to help with brain health too. So think about that in terms of what's going to get you through the next 30 or 40 years, and still enjoying your health.
100%. Well, thank you. Thank you for the book. I will put a link to it in our show notes and keep up the great work, Dr. Faubion. We need more of you.
Well, thank you. Same to you. And I appreciate you getting the message out there about menopause and hormones and all of it. So appreciate everything you do. Thanks so much.
Well, that's our show. Join me next week for a wild ride of a conversation I had with Irish freediver and visual artist Nina McGowan, who shortly after turning 50 secured a world record dive of 43 meters, that's 141 feet for the Americans in the house, no fins, that involved holding her breath for 2 minutes and 10 seconds. We talk all about her journey from the dance floor in her 20s to the ocean floor in her 40s and 50s, and how she's broken records in the midst of menopause. So come on back for that one. And until then, you know what to do. As always, stay feisty. You've been listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I'm your host, Celine Yeager. The show is edited and produced by the strong, talented, and amazing women at Live Feisty Media. Follow us on social media at Feisty Menopause. And please help us spread the word. Screenshot and share this episode on your social media channels with the tag @FeistyMenopause. Share the show with your friends. And please subscribe, like, review, and rate this show wherever you get your podcasts. Word of mouth and good reviews make it easier for other listeners to find. Thanks for listening, and as always, stay feisty.